Good evening, and welcome to all of you. Thank you for your interest in tonight's program, and I'm glad to see we've got a fair recognition of the different sexes and different genders in the audience, so that's wonderful. This is our 46th event from the last 7 years, so we're really glad you're here. My name is Keith Rose, and I'm your moderator for this evening. But before I forget, I want to say a sincere thanks to Scott Warnick. Scott emceed the last program. He hosted the event, and I really appreciated him giving me some time off, but also I learned a few things from what he said. So, Scott, if you're watching tonight, you're welcome back anytime. Mm-hmm. So, we have an audience here at the Midland Cultural Center. We have people watching on TV in Rogers, by Rogers throughout Simcoe County. And we have streaming, which is our current mode that most people are using, the broadcast live on their electronic device, and they could be anywhere in the world. Okay? So, speaker introductions. Let me introduce these three wonderful volunteers in front of me tonight. Annie Dukas, Dr. Ann Dukas, is a vascular surgeon from Royal Victoria Regional Health Center. Sandra Eason-Bruno from the North Simcoe Muskoka Specialized Geriatric Services, and Monica Menicola from the Osteoporosis Canada and the Regional Integration Lead for Simcoe County and Muskoka. So welcome to all of you.
Thank you.
So there's one of the talk shows that, to get a little interest going, they ask each of the people that are on the talk show to tell us a little bit about themselves. They ask them a question. And so that it isn't going to be something that you found in the bio, if you looked at it. It's not in there, so listen. So, Annie, can you tell us a little bit about your family and how that influenced what career you chose?
Yes, so my family, my father and my sister are both in medicine as well, and they're cardiologists. They're the more medical field, and I have a couple aunts and uncles, also family doctors or in psychiatry. I am kind of like the black sheep of my family as I went into surgery, which is a little bit separate. And I think the reason why it happened was because when I was in medical school, I was told that I should just try it. Just go and take a look. And I fell in love in the first OR. And many, many, many years later, and lots of lack of sleep, I am now practicing as a surgeon.
Well, welcome. Thank you for sharing. Sandra, you've had tons of jobs. You've been at this longer than 20 years, I hear. Mm-hmm. Tell us what's been your favorite job.
I would say this is probably my favorite job. I certainly have a great passion for working with older adults and caregivers. And I remember about 10, 15 years ago, walking out a door with somebody and we were chatting and they said, "So what do you want to be? What do you want to do?" And I was well into my career at that point in time, and I said, I want to build and I want to run a regional program for seniors because we don't have one in this region. So I've kind of landed my dream job.
Great, good. Well, thanks for sharing all the things about your dream job with our audience tonight and us. Okay. Monica, you told me when we met that you knew the roads in Simcoe County really well. So I thought, well, I can just ask you how I get home because I can't even find Tim Hortons in Simcoe County. Anyway, so how did you learn all the roads in Simcoe County?
Well, I was fortunate enough. My parents had an aggregate road construction business, and so my dad graveled a lot of back roads of Simcoe County, and then that led to me to get a job for the County of Simcoe, teaching in a recreation department where I had to know all of the small rural communities. So I taught swimming lessons in Penetanguishene in the morning and would have to be in New Lowell Pond in the afternoon, to Scanlon Creek in Bradford, over to another community up in Wishago. So it didn't take long for me to get to know the roads as a youngster, but then throughout my career, I've continued to drive every back road and know every back road. So I'll give you the shortcut when we leave today.
No Zoom calls in those days, eh?
No Zoom calls, no. The kids were very fortunate, for sure, to learn swing lessons in person back in those days.
Okay. So as I said, there's more detailed biographies in your program. You can get a chance to read it. You can just download it when you get home, okay? Some collective thank yous to our Health Advisory Committee, which none of us could do without. We all come up with crazy ideas, and then we straighten each other out, and we get along, and then we produce the programs, and we have fun doing it. But specifically, I'd like to thank Kathy Wolfer. Kathy, put up your hand in the back for spearheading this program, all the work. Thanks, Kathy. A little later on in the program, I'll acknowledge our 7 local sponsors. We have an extraordinary staff here at the Midland Cultural Center. The promotions, Michelle, programming, Shaban, and upstairs on the audio, Glenn Irwin. So thanks to the 3 of them for keeping us whole and putting us together tonight. And the one person I don't want to forget is Josh Katova, because he said he would blank me out. That's the guy that manages the TV camera. So, but I'm really pleased that Josh is here tonight. I had my doubts. But he said he would arrange for the Barrie Colts game, if they were in the playoff, to be Tuesday and Thursday night, because then he could come and broadcast our program tonight, and it would be broadcast in Barrie. And Josh, thank you for scheduling the Barrie Colts on Tuesday and Thursday night, and we'll hope they win tomorrow night too. Thanks, Josh. So our format tonight is similar to previous programs. We'll have good discussions with our speakers throughout the evening. I hope lots of interchange as we go between not only me, but between the different speakers, because they seemingly very different vocations and very different interests. There are actually some common features of all the things that they're going to talk about. So we look forward to that. So just make a couple of opening comments. All of the areas that our speakers will be discussing have differences related to sex and gender. There are 3 specific topics we're going to cover that relate. 2 of them relate to disease, and that's vessel problems. And vessel problems lead to heart attacks, they lead to angina, and they lead to strokes. And the other one we're going to talk about is osteoporosis, bone health and bone disease, often a common cause of hip fractures and spine fractures. But the third issue, which just seems kind of the outlier, but I don't think it is, relates to caregivers. Those family members who provide a wide variety of services to their parents or their spouses, and it's all about love because it isn't about money. These people are not paid. So there's lots of commonalities as we go on because there's differences in sex and gender on all of those issues. So we'll hear about them as we move forward tonight. I'd just like to do a little survey on the audience to find out your personal experience with these 3 issues. So for angina, heart attack, and strokes, how many in the audience have either had the problem themselves or somebody in their immediate family? I'm putting up my hand. I think about 40%, maybe 40%. All right, Henny? Okay.
Maybe a little bit more.
So let's move on to osteoporosis. How many have osteoporosis themselves, or a mother or a father or a relative that has osteoporosis? 1, 2, 3, 4. So about 10%, Monica, about 10%? Okay. Now the other one you got to think about a bit is your interaction with caregivers. So these personal caregivers, as I've defined them, do it for love, they're looking after a relative. How many of you have been a personal caregiver, needed a personal caregiver, or had to work to find somebody in your own family that would be a personal caregiver for one of your relatives? How come? About 30%, so 10, 20, 30%, so a fair number. And I'm going to put up my hand to the last one. I didn't realize it until you started talking about it more with me, about just looking after somebody's welfare, being the only person that can help them decide what kind of care they need or where they need to live and that kind of thing. And that really is a big part of caregiving too. So, okay. The other thing I thought we should start with is we should define sex and gender. So everybody knows what the difference between sex and gender isn't. So just in case there's somebody that doesn't know the difference between sex and gender, Sandra, could you take a stab at really defining that? This is unrehearsed, Sandra.
Oh, apparently. Well, we certainly know there's different genders. I mean, there's males, there's females, there's the genetic disposition, but then there's also the cultural pieces too. So male, female, but then we also certainly have a growing group that are identifying as non-binary or LGBTQ two-spirit plus. So we certainly have some changing gender identification these days.
And we felt it important for this program that we identify both of them, because it's never really right to use one without there's some specific areas. So sex is really about your chromosomes and your physical characteristic. Gender can be a whole lot of cultural things and is a much broader statement to make. But anyway, so thank you, Kathy, for including that in the title, and I hope we've defined it for the audience up front. So at this point, Annie, sitting on my left-hand side for some reason here, can you take us into your world of surgery and the patients that you see and what you do for them?
Yeah. So I thought I'd just start off by saying a vascular surgeon is somebody who operates on arteries outside of the heart, also veins. And so we deal predominantly with disease scarring of the artery, so atherosclerosis. And it's the same disease that you see around the heart, so coronary artery disease. And so there's a lot of overlap with what I do and with what cardiologists do and cardiac surgeons do. So not a lot of people know what vascular surgeons do unless you see one as a patient. I was thinking while getting ready for this talk, I was trying to think how could I break down such a big topic, cardiovascular disease, for everyone to kind of digest. And specifically, it's a big topic because there are quite a few differences in women and men and how this disease presents, how we treat the disease, and the outcomes in women. And this is across the board for both heart disease, strokes, because it has to do with arteries as well, and peripheral arterial disease, so disease of the arteries in the legs and the rest of the body. And so while I was thinking about this, I asked some of my family members and I asked some of my friends, what do you think heart disease means to women in terms of, do you think it's important? Or I asked the question, what do you think is the most important disease in older women that we should care about? Some of them didn't really have an answer, were kind of waiting for me to give them the answer. Some of them said breast cancer, which is not an unreasonable answer because it is the most common cancer that's specific to women as we get older. But none of them really said the most important one and the biggest one, and that's heart disease. Heart disease affects about 40% of women over 50. And heart disease is actually the number one thing that causes mortality in women after 50. So everybody, when we asked that question at the beginning, how many people have had somebody who's had a stroke or heart attack or anything involving vascular disease, there was quite a few of you that put your hands up. And that makes sense. But this experience that I had with my friends and my family, and some of them are in medicine, as you know, was actually documented by the American Heart Association, that they said that when they surveyed women, only 13% of women thought that heart disease was important and was the number one disease that women should be worried about. And so I thought that was very interesting. So today I kind of, after having spoke with my friends and family members and thinking about it for a while, I thought, what are the things that I want to make sure that I get across to you guys today? And it's going to be about heart disease in general because it affects both men and women. It's also the number one disease that causes mortality in men over 50. And the three main things I wanted to get across is obviously the thing that I just said, which is heart disease is the number one disease that causes mortality in women over 50. Number two is that the best way to treat heart disease and peripheral vascular disease and stroke is actually preventative measures, is not figuring out the best surgery, not figuring out the best medications, but figuring out how to stop it from happening, how to identify people who are at high risk of having it, and giving them risk reduction strategies, and also being able to connect with healthcare individuals, either physicians or nurses, that can identify people or that are at high risk. And then obviously the last thing I wanted to touch on is the uniqueness of heart disease in women. So how do we break down heart disease in women? Well, there's obviously the biologic and physiologic factors that occur in women that don't occur in men. There is how the risk factors that are more common in women, and what are the things that I was saying that we could prevent. What are the outcomes in women, and why is it important that we continue to research and continue to look into why women have worse outcomes or why women have different outcomes than men. And then kind of the special considerations. And then I think I'm going to talk on things that are relevant, I guess, in this day and age with media and how we interact with learning information about treatments. And so I hope I can have a little bit of time to talk about that too. So when we think about heart disease in women and what the difference is that women go through menarche and they have higher levels of estrogen and progesterone. And not everything is understood about this, but one thing that's understood about going through your menarche and being a woman is that these levels of estrogen reduce the amounts of cholesterol in your body, specifically the bad cholesterol. They reduce the inflammation of the arteries. And so in general, in healthy women, we see them developing heart disease about 10 years after men do. And we see in this heart disease, we see them developing peripheral arterial disease even later after that. They're less likely to have artery disease of their large arteries, so aneurysms, if you've ever heard of that. And they also, when they're in childbearing age, are less likely to have complications with their arteries. Now, apart from that, there is some inflammatory mediators that women have that reduce the inflammation in the arteries. And essentially, we're talking about scarring of the arteries. Now, women still develop heart disease. As I said at the beginning, it's the most common disease that women develop over 50. So what are the things that put women at risk? And the number one thing, which is also very similar to the number one thing in men, is actually smoking. So smoking is the number one risk that you can do in your lifetime that increases your risk of heart attack, stroke, and disease of your arteries outside of your heart. Unfortunately, unlike men, women tend to have worse outcomes when they smoke. And they also, in a recent study with the American Heart Association, they're less likely to quit. There was some proposed reasons for that, and that is that they don't have as much social support or they have more social stressors. That was just guesses. I'm not too sure. There's other similar risk factors that happen in both men and women, which is high blood pressure, high cholesterol, and diabetes. Now, what's unique about diabetes in women is that women who develop diabetes before they hit menopause, the protection that I told you about, the delay of 10 years of getting heart disease, is actually removed. So then women start developing heart disease at the same rate as their male counterparts. So that was an interesting tidbit of information that I learned that I thought was important to at least tell people in the community, but also family doctors, as it allows us to identify people who are at higher risk of heart disease and maybe intervene beforehand. Women also tend to have what we call metabolic syndrome, which is more of a medical term. It just means having high blood pressure, high cholesterol, and diabetes, and central obesity, where you gain your weight and mostly in your abdomen. And when women have that disorder, they tend to have much worse outcomes for heart disease than their male counterparts.
Just going to interrupt for a second. You said to me you weren't going to talk about pregnancy, but I'm hearing that gestational diabetes, so diabetes during pregnancy, can be one of these major precursors to the problem. Is that right? Okay.
Yeah, so I mean, I was going to touch on pregnancy because recent study, which is I'm finding very interesting, is that they are looking at a woman's history of their menarche. So whether they develop if they go through menarche early or they go through menopause early. And they found that people or women who go through menarche early have shown increased risk of developing heart disease, as well as women who go through menarche early, whether that be for surgical reasons or for natural reasons. But they've started looking at women's outcomes in pregnancy, so preterm labor, stillbirth, as well as gestational hypertension or diabetes. And all of these risks, all of these diseases actually increase your risk of heart disease too. There's a lot of proposed mechanisms that people say for that, for why it happens, but I think that when you have a patient or when you have a family member who's noticed this a lot, I think that you have to kind of, a little light bulb has to go off and you have to be like, are you at risk for heart disease? So, yeah.
So you came here tonight to hear about heart disease, and we're talking to you about preventive measures in pregnancy, but I think that's okay too.
Yeah.
Go ahead.
Yeah. And then, the patterns of disease in women. So how does it present? So how are you, some people are probably thinking, do I have heart disease? Nobody's ever told me I have heart disease. Women tend to present in very subtle ways. Now, as a woman going through medicine and learning about this stuff, I always tend to think, is it that women present abnormally because when these trials, when we started collecting data on people who have heart disease, was it that we just included men and so then we considered that normal? And so that's how the dialogue kind of goes in medicine, is that there is no normal, it's just things are different in different individuals. But in general, women tend to have symptoms of fatigue and poor sleep before a heart attack. About a month before they'll present with that. They have odd symptoms of discomfort or indigestion, but that's not the most common. And the classic symptoms of, when you see the pictures of a man holding his chest and his left arm hurting, that doesn't usually happen in women. Their symptoms are more vague. Now, when we're talking about disease of the peripheral arteries, the arteries in the leg, because it develops later in life for women, they already have other things that could contribute to poor mobility or discomfort in their legs, and so like osteoporosis. So they tend to be misdiagnosed or not diagnosed when they present. Now, more often than not, it's been documented that women present before they're actually being diagnosed at being at risk of this. So they present to hospital with a heart attack, or they present to hospital with an ischemic leg, so meaning no blood flow to the leg. They also have poor outcomes when they get interventions. So women are more often likely to pass away from a heart attack after their initial heart attack in 1 year. Women are more often to fail intervention to save their leg and go on to amputation versus men. And women also don't tolerate, they're more often to have stroke after operative repair of their arteries. So their outcomes are not as good as men. They're not much worse, but there has been a difference in both of them. There's some proposed reasons for this, that they have smaller arteries, that they were caught later on in life, that they weren't on the right medications beforehand because they didn't seek help until that time, or the fact that they're coming in an emergency situation, which tends to have worse outcomes across the board. In disease of the arteries in the body, we know that women tend to not present, and so was the most important thing that when I was reading this, and I thought that I wanted to get across, is that what are the factors that prevent women from seeking help or asking their doctor or thinking that they have something wrong? And just like the other question I had, this has actually been looked at, and one of the proposed mechanisms is that women are older when they develop this disease, and so they can be more isolated. They tend to be the caregivers for men, and now this was based on research that was done 10 years ago, so it could maybe change now, so we'll keep that in mind. But, and they tend to not be as active when they develop the disease. So they don't get chest pain, they don't get pain in their legs. And so that could limit them from being diagnosed beforehand. Also, I think that because they have this protective factor, sometimes when they're at risk, they don't get treated for the disease. And then lastly, I wanted to touch on a couple of things that was present that I thought was pertinent, is that recently, about 5 years ago, a article came out talking about aspirin, which, I mean, if most of you have been connected to the media at all, you know that I would say 5 years ago, family doctors and cardiologists were probably lobbying the government to try to put aspirin in our water supply to try to prevent heart attacks. And then an article came out, and there was a flashy title, because that's how you have to get readers. And the flashy title was, "Maybe aspirin isn't as good as we thought it was." And so the article was good. It did cover some of the things that aspirin can and can't do, but it gave the impression that you shouldn't be on your aspirin. And so some patients individually, without speaking to their physician, their cardiologist, or family doctor, stopped their aspirin. And some people did ask their family doctor whether aspirin is important. And I still see patients asking me about whether aspirin is something that they should take. And this was an interesting article, because it did tell you that you should talk to your family doctor, but it really didn't talk about the people who this study was specifically focusing on. And that's people who've not been diagnosed with heart disease, with hypertension, with diabetes, people who don't smoke. So people are healthy. It is true, the benefit of aspirin is kind of not as good as the risk of having a complication of being on aspirin. And specifically, that risk is bleeding. So GI bleeding, so gut bleeding, or having bleeding in your head, which was the more rare cause. Now, if you do have anything that puts you at risk for heart disease, you actually get a benefit from aspirin, and it outweighs the risk of bleeding. And so a lot of times I just tell people to keep taking their aspirin, but try to have a conversation with them so they understand why, because nobody likes to take medications. So that was unique, is that I think social media and how we interact with social media has changed the game in medicine, and specifically how we interact with our physicians, and keeping that trusting relationship, which is so important for both the physician as well as the person who's coming to see them, the patient. And then the last thing I'm going to touch on is just hormone replacement therapy, because I know that was also probably 20 years ago was big in the media. So the risk of being on hormone replacements after, for example, menopause or early menopause, or surgically induced menopause. And there was a lot of fear around taking these medications because there was increased risk of heart attack or clots in your veins. Now, they've changed the medication regime since then, and a lot of new trials have come out that show that there isn't an increased risk. There was only an increased risk when you had a certain combination of medications, so estrogen and progesterone. So this is constantly evolving, but in general, there isn't an increased risk. So the benefits of being on these medications are there without significant risk to your heart and arteries. Now, I would once again say, if you talk to your physician, if you have any increased risk of taking these medications, you shouldn't be on them. So once again, I'm going to just repeat the things that I thought were important, that I wanted to make sure you guys got across today. So, which is, number one is heart disease is the number one disease in women over 50. It's the number one thing that causes mortality, okay? Number two, the best way to treat heart disease is through prevention. So identifying when you're at risk, doing interventions like lifestyle modification, quitting smoking, being on risk reduction medications, talking to your family doctor, being aware that you have these risks. And then the last thing is that heart disease and peripheral vascular disease in women is different, and that we have to continue to be vigilant in identifying the differences so that we can better treat people and so that you can have better qualities of life and longer life. So that's kind of all I have to say, but I'm definitely willing to answer questions.
Thanks. We've got a couple that I've had handed in or fed to me, and so thanks for summarizing in 3 very distinct areas and leaving us with a clear message. Thank you very much. FAST, F-A-S-T. How many in the audience are familiar with those terms, that acronym, FAST? Okay, not very many, so maybe it would be worthwhile to go over FAST, the signs of stroke,
Oh, yes.
and say, is that different for women, or how does that relate?
So that is like the generic signs of stroke, and so I usually see people after they develop stroke, but the generic signs of stroke are not different in men and women. They are very classic in terms of you will develop weakness or sensory loss on one side of your body. Usually you can develop blindness on one side of your body, on one eye. You may have difficulty speaking. There is always a concern that dizziness or lightheadedness or fainting is a risk of stroke, and it's usually never that symptom alone. So dizziness is not necessarily stroke. You usually have to have another symptom that occurs at the same time. So weakness on one side of your body, weakness on one leg, or feeling numb or tingling, or not droopiness on one side of your face. And a good way to remember why is that a stroke is basically low blood flow to a portion of your brain, okay? And when this happens, it is going to affect one part of your brain. If it affects a large part of your brain, you won't be conscious. But if it affects a little part of your brain, you will have a small area that will not work anymore. And the way most people's brains work is that the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. So that's what you're going to be looking for.
Okay.
Yeah.
But no difference in men and women on that?
There
so-
is no difference. There's
Okay.
difference in outcomes, but there's no difference in presentation.
Okay. So thanks. I'm going to stop here with these questions
Sure.
because I'll come back if we have more
Of course,
time,
yeah.
or I'll incorporate them into something else. But thanks very much, Andy.
Okay.
Sandra, tell us about seniors and caregivers, and I mean, you are the boss of this subject. You have been looking after seniors for a long time, but not just in your office. You have a mother you look after too,
I do.
and you are the personal caregiver.
I am. I
Okay.
am. I'm very
So-
privileged.
I can't imagine a better speaker for this. So-
Thank you. Well, I think our team does an awesome job. I've been removed from sort of direct care for a little while now, but we have an amazing team. And when we're working with older adults, it is always the older adult and that caregiver system around them. It's like working with children, right? It's you can't do one without the other. And so when we think about the term caregiver, there's different terms that get used. There's, some people will say caretaker, care provider, caregiver, care partner. I am not a linguistic specialist, but in my head, when I think of caretaker, that to me is more of a custodial, sort of operational, environmental kind of role. Care provider, when we talk about that in healthcare, that tends to be the paid individuals, the healthcare providers, whether they're personal support workers or nurses or physicians, but those are what I think of when I think of healthcare provider. Caregiver and care partner are really what I think about when we talk about the people that surround individuals and provide care to them. And there's a really interesting perspective when you think about those two terms, caregiver versus care partner. More and more the language these days is moving to care partner because that's what those individuals are. They don't just give care. They are the ones that are there for the appointments. They provide the medications. They do the day-to-day care. So more and more I think we're moving in the health system to the concept of care partner because that's critically important. In the province of Ontario, it's estimated that there's about 4 million caregivers. And those caregivers provide about 75% of the care that's provided in this province, which is huge. And at a national level, the estimate is that there's probably about $30 to $40 billion of free labor that's being provided by the caregivers across the country. It is a 24/7 job for many of them. There was a great article that was pulled together by the Ontario Caregiver Association, or Ontario Caregiver Organization, and they did some data. They did a survey in October 2022, and what they found was that about half of the individuals that completed the survey, so about 850 people, but half of them are what we call the sandwich generation. So it's those that are in the middle that are providing care to that aging population and may have younger sort of children that they're trying to deal with as well. About 69% of those are providing care to individuals over the age of 65. So the majority tend to be older adults. And about a third of them are spending more than 10 hours a week providing care. And that doesn't include the time it takes to get to the loved one or come home. So it's a substantive amount of care that's being provided and time that's being taken outside of people's regular days. There was a great article that was pulled together where partners in the province tried to cluster and describe the different kinds of caregiving groups that are out there and what typically is associated with them. And they came up with about 10 or 11 different kind of groupings and pictures of caregivers and the type of individuals they provide care for. But at a high level, when you think about caregiving, it could be for a short episodic kind of thing. So somebody's had a knee replacement, or they've fallen and fractured their hip, which Monica will talk about. And so it's short term, it's kind of episodic. There's longer term illnesses that people provide care for, and that can either be for an aging individual, a parent, a spouse, a grandparent, or in some cases it can be a child. And there's lots of caregivers out there that have children that have lifelong kinds of illnesses they support. And then the other grouping is providing support to individuals with mental health issues, which has a whole different set of sort of experiences and stress tied to it. And when they looked at the different categories, the ones that were lower in terms of stress on caregivers were those episodic things where there was kind of a beginning and an end. The higher ones were those that were providing support to individuals with mental health issues, and those providing support to those older adults, those parents, those spouses, or those grandparents. And if we think about caregiving and we think about the impact of it, it's hard work. For anybody out there that's done it or had family members that have done it or neighbors or have witnessed it, it's tough. For many, it can be 24/7. It can be sort of the day-to-day care needs. When I think of older adults, if you're dealing with complexity and sort of multiple issues, whether it's cardiac issues, osteoporosis, cognitive impairment, things like dementia, it can be 24/7. You are providing what we in healthcare called ADLs and IADLs, so things maybe like bathing, driving, groceries, finances, meals, continence care, getting somebody to the bathroom. It can be very intensive. You are coordinating appointments, you are navigating the system. So it's an incredibly stressful role, and I don't think we give people enough credit.
One of the challenges, and they were comparing doctors and nurses. Doctors like to cure, and nurses like to care. Mm-hmm. And as a caregiver in your own family, you're caring. So it's hard to fix some of those things that your parents have. So how do you feel good at the end of the day about being with them? Because if they've lost some memory, you're not going home to repair that memory. You can't do that. So how do you feel good after you go visit your mom?
Yeah, so my mom's 95. She'll be 95 next week. And it's not my mom anymore. There are many days where it is my mom, and I'll get my name. Her world revolved around her family and her children. She has 3 grandchildren this year that are getting married because she hasn't been to any of those. She's got 3 brand new great-grandchildren that she can't remember anymore, and she can't connect who they are. And so for me, you find those moments where my mom is there with me, right? Where she'll get called my name, or I'll show her pictures, and we'll try and connect the dots and try and help her understand where they are. But it's challenging. It's tough. The conversations start what would have typically been a very engaging conversation is really quite one-sided now. And so I have the benefit and the privilege in the role that I'm in and understanding what I'm seeing, which many don't. And so it helps you appreciate where it's coming from. And I'll tell you, my mom is pleasantly confused, so it's easy. And she's in a retirement home because we can afford to do that. And so I know she's in a structured environment. I know there's people that have eyes on her if something goes sideways, if she has a fall. You know, I'm in there about 5 days a week. So you talk about sandwich generation. I've got 2 young boys and I've got my mom. But I make the most of when I am in there with her. And that's just what you do. You find those moments of clarity and those moments where it's that person that you know and you love, and she's still in there. But many don't understand and appreciate that, and it's hard. It's much harder when you have sometimes older adults who have dementias that have behaviors tied to them. So they could be aggressive, or they could be wandering, or they could have, there's different types of dementia, one of which is frontal lobe dementia, where the front part of the brain is a little bit more impacted. And they lose that social inhibition, and they come out and say things they never would have said. And it can be incredibly upsetting for family members. It can sometimes be incredibly upsetting for staff providing care to them, because they don't always understand it either. You know, I could certainly tell you stories about some of those. So it's tough. So I've got to find my mom in there some days, and it's still my mom, and she was a great mom, and so it makes it easy. It was important. So when it comes to things like caregiving, there was some study that was done, a survey where 79% of those individuals that I'd mentioned before in the survey were doing the care that had historically been done by, or could normally be done by, a personal support worker. So to try and help you conceptualize what that care looks like, 63% of those individuals hit a breaking point in the previous year in that survey, but they knew they just had to keep going on. And that's how tough this is for so many of them. And 37% of those that were still working had considered giving up their job because it was just becoming too much. And to understand what the experience is like for them and what supports they have, 1/3 of them had never asked for supports for themselves. 1/3 of those had never had trouble accessing support. So if you think about providing care to a loved one, maybe with dementia, you may want to go to that program at that Y that runs at 10 o'clock in the morning, but you can't get there. About half of them had been to an emergency department or an urgent care clinic in the last year, and 1 in 5 of them had been on a monthly basis. And what's interesting, that I found incredibly interesting, was that of those that went to an emergency department, 44% of them couldn't get the care they needed at the physician or at the primary care office because the needs were too serious. So this is the level of complexity that these individuals are providing care for. 24% of them, the service wasn't available at the primary care office, and I think it was 17% of them, the doctor actually directed them to the emerge. That's a huge number. That just speaks to how much it is. Only 11% went because they were entirely overwhelmed, which is still 1 in 10. But that's not why they're going. They're going because the care needs aren't available for them in the community. Now, when we talk about men and women, which is part of the conversation today, what I found incredibly interesting in the sort of the categorization was I expected way more to be women. And the actual percentage in many of them was far more comparable. Except in those with mental health, it looked like there was a greater proportion that actually were provided, the caregivers were men. And in the group that was under 26 providing care to a parent, a grandparent, whoever it was, about 70% of those were women. And it was only in that particular category where that non-binary group started getting identified, because it's that younger generation that's beginning to more and more speak to the different genders and how they identify themselves. And so, you know, you look a little bit at gender and you think, I thought it would be more women, because I can tell you when I see them, and Annie was saying the same thing, it tends to be women that are caregivers. So it's surprising that the numbers were as high as they were. And in one article I read, it said that women provide 50% more caregiving than men. However, in other articles that I read, it said it questioned some of that data, and it really wondered whether there was any sort of clinical significance. And so we were talking about it just prior to, and you know, if I'm ever asking questions about caregivers, the first thing I will ask will not be, what gender are you? You know, it will be, what kind of support system do you have? What kind of knowledge do you have? What are the resources that are available to you? What are you like financially? And when we think about the concept of caregiving, so much of it is culturally driven. So much of it is age and generation driven. And so, you know, I really do wonder how much of it is truly tied to gender, sex, genetics, and how much of it is tied to the evolving world that kind of is around.
So how much control do patients have over who is their caregiver? So do mothers in general, or females in general, and you can tell me if I'm wrong here, prefer to have another woman looking after them versus a man? And what do men patients, do they prefer? Or do they just get who's ever available? Like, how often do you ask the patient?
That's a great question. You know, oftentimes there are not a large percentage of healthcare providers that are male delivering day-to-day care. So the stuff that you're talking about, right? So oftentimes they end up with females. Once again, it's generational. So my mom, even who's 95, you know, if I go in there and I try and change her, you know, she'll kind of be covering up on me, even though it's me and I'm her daughter and I'm a female, right? So sometimes there's a generational piece. Sometimes we have to be really careful because there's trauma in the history of that individual that you have no idea. Or if they have any sort of a dementia or cognitive impairment, there could be a history of stuff that starts bubbling through that may otherwise not have come through, that becomes a little more obvious. And then usually what the teams will do is they'll do their best. They try and, you know, if it's a male, they'll try and see if there's maybe a male on the floor that can provide care, or send somebody into the house that's male.
Well,
But
I remember in our
it's a little harder.
conversation you said to me something about my brother. My brother helps out a lot. He makes dinner for me, he runs errands. I don't think he's going to change my mother. I don't think he's going to look after my mother. God,
No,
I'm out of school.
No. And so, you know, when you think about that from female and male, the situation is the same. My mom is the same person. What I give to it is different than what my brother gives to it. And part of that, is it cultural? It's not genetics. Is it because I'm a nurse, because I'm a geriatrics nurse, because I live 5 minutes away? I mean, there's a part of it, but again, I think there's very much a generational piece to it from my mom, and the dignity and the respect and sort of that privacy piece for her. If you're changing, or, you know, continence care or anything like that, if I need to clean her or change her, it's way easier for me to do, and I don't know how comfortable my brother would be doing that. He's great, but, you know, there's certain lines sometimes.
Yeah.
So
many issues came out about what's the default position for the caregiver and who's best able to do it. And it's challenging. And when you read that descriptor of all these patients that had the interviews, this is something you can go, what did I say? It was caregiver persona. If you Google caregiver persona, it's got stories of about 11 caregivers here. And they're from all walks of life, looking after such a wide variety. But in any one, you can see what they're doing is challenging. And in many situations, they're happy to be doing it. So it was I found that very informative. So okay, carry on. Sorry.
No, I think I'm good. I think really the moral of the story, or the key message, I guess, is that every caregiver is different, and it's really important for us to understand what their experience is, what they're going through. How do we get them involved to make them really a partner in care, and understand and appreciate that not everybody has the same expectations of what their obligation, their sense of obligation, or their desire to be involved with. It's you know, if there was trauma in the family and the history, they may not want to be there on a regular basis, right? So it's really important for you as individuals who might be providing care to be able to share those stories so that the care providers can understand. And it's equally important for us as care providers to ask those kinds of questions so we can best support people.
When you look at, or you have a team of people that work with you, and one of your jobs is to assess patients around where they're at with their level of care that they will require. Is that too simple? But, you know, kind of how much they need. Where does the role of the family caregiver fit into that equation? So if somebody says, I live by myself, and somebody else says, I have 2 daughters that visit me on a regular basis, how does that change your assessment? And I'm going to come back to you on this one because you're discharging patients that need home care too. So, but go ahead first, Sam.
Well, I mean, I think any plan that we make has to be based around the needs of the individual. So I think, if we go in there and say, well, this is what we're going to do, that is totally the wrong approach. We have to understand what's available, where are you at, and how can we complement or how can we meet some of your needs, right? Because you're right, some of the individuals have no support. I've seen it. They're on their own, and I'm looking at Kathy because Kathy's seen it through home and community care, right? You try and do the best that you can and patch resources or local organizations, in to provide support. Those that have supportive families, it does make it easier because you know that they're in there, there's eyes on them. So it really depends on what's available, and it's those key questions you have to ask to really understand what the needs of that individual are to build the plan around.
What's your experience, Annie, when you're debating about, do I keep this patient in hospital?
Yeah,
do I
I'm
call
riveted.
for home care?
Yeah, I'm riveted listening to this because it is so important in the patients that I take care of, and that it's actually one of the main questions that I ask in my first interview with a patient. Who do you live with? Do you have any supports that live with you? Do you have any supports nearby if you have family members? How independent are you? Would you feel safe going home? My team in the hospital, which is, like you said, it's a team, consists of a discharge planner. Usually I get social work involved as well as occupational therapy and physiotherapy. It's paramount into the full scope of care of a patient with any type of illness that requires an intervention, in my opinion. I do have one question because it's biting at me, is that I'm listening to this and the amount of, you said hours, the free labor.
Oh.
And the way I look at that, and I was everybody knows our population is getting older if everybody looks at the population graph curve. And I'm wondering how, does the government give subsidies or do they give support the way, for example, if you have a child, you get some support? Is there any support that the government could give to caregivers, to documented caregivers? Because the way I see it going forward, that's going to be a major issue in Canada the next 10, 20 years.
I think that's certainly one of the areas of advocacy. There's a lot of push right now to give individuals almost like a pot of funding for the caregivers to use as the caregiver sees most appropriate. So there's a real push for this. Right now it's system driven. We tell you what's available to you and we give you what's available, within the system. But sometimes you don't want somebody coming in 2 hours a week to help bathe mom or help bathe your spouse. Sometimes you would rather have use those funds to pay for transportation so that you can get them to a day program, and you would rather do the bathing yourself. So there's a real push to try and figure out how do we find that balance between the public use of funds to cover the services, because if everybody just chooses to buy their own things, then you start losing access to services. And how do we allow the caregivers to actually purchase what they truly need? And that's where the whole concept of co-design comes in, and we really need to be building our system with the input, not just of older adults, but of caregivers as well, to make sure that we're designing it properly.
Okay, just one more question. Do you think COVID or the lockdown, let's just call it a lockdown, made people more aware of the contribution of family caregivers? First of all, in long-term care, there wasn't that extra pair of hands. There wasn't, because frequently those people were coming in and staying with their parents for a long time, and all of a sudden they can't. I actually think I heard that you moved your father to be with you because you didn't think you couldn't go and visit him. You just moved him in. Is that right?
For my mom, yeah.
Yeah.
Yeah,
Your mother, I'm sorry, yeah.
Yeah, I was watching what was happening in Europe, and I knew what was coming. And so I knew what was going to happen, and I had the ability, I had the knowledge. She was, mobile enough and well enough that I could bring her in with me, and I had the space to be able to bring her. So once again, I had the privilege of being able to do that. And so, from March through August that year until my boys went back to school, she came and stayed with us. And it was, I'm going to tell you, it was a challenge. It was different having somebody new in the house. But COVID was devastating for older adults and caregivers. The images, if you saw any of them, of the caregivers being locked out of the long-term care homes and trying to reach in through a window and have contact. And you saw the impact of the loss of caregivers on older adults. So not just in terms of the day-to-day care. There was a great study out of Europe. And we did a little bit of work on something we called confinement syndrome, where they saw a huge number of older adults pass away within a long-term care home in France, and post-autopsy they thought it was COVID, and it wasn't. It was dehydration, because nobody was going in to feed them and with the fluids, because the staff was all sick and the staff was afraid and the staff wasn't going in. And how many people we heard, some of the stories we captured, people died of loneliness. I had a colleague who was a social worker out in New Brunswick and struggled. They wouldn't let her in even when things started to open up. And within a week or two of her being in, she watched her mom deteriorate while she wasn't able to be in. She couldn't use the phone anymore, couldn't engage. And within a couple of weeks of my colleague, it was Susan, going back in, engaging her and bringing her the food, she started to be able to recognize her again and started using her name, whereas when she first came in, the role of caregivers cannot be underestimated in the system, and COVID really highlighted that. Have we learned from it?
About 7 or 8 months ago, we did a program on long-term care, future of long-term care in Simcoe County, and one of the speakers was Jill Knowlton, who works as a director at one of the local long-term care. And she said the one thing that we can do coming out of COVID and what we have learned is we have to enshrine the role of that family caregiver in legislation. It really stuck out as, that's the extent we're going to have to go to address just what you asked, and to make sure that these people are recognized. I don't know how far that is, because it's it's a difficult definition. I don't know where it'll go, but I thought it was fascinating.
And I think as long as we keep calling them caregivers, and I think that's why I like the term care partners, because it really does make it a mutually beneficial kind of thing. But there is a lot of work, and I'm not sure we've learned entirely from it enough that it's changed practice.
Okay. So I had one more question about supports, but let me do it a little bit different. Since Monica, you are also a care partner. Do you call yourself a care partner?
I do. I call myself a care partner. I have been for 20-some years. I actually was a clubhouse sandwich. I cared for my grandmother, my mom, and my children were young at the time. And so my husband and I were clubhouse sandwiches. So I currently live with my dad, who's going to be 90 in October. So lots of experience.
How do you find supports to help you? Because A, you're successful at it because you've been keep coming back.
I don't know. I'm not going to put my hand up next time. Because no, I think from the care partner piece for me I've really seen a shift in the last 20 years. So 20-some years ago, if I reached out to a service agency and said my grandmother needed this, it would be like, well, who are you? I can't tell you anything. There was always this sort of, it wasn't like I was part of the team or wasn't a partner. And I have to tell you, in the last few years, and especially I think as many sort of negative things with COVID, there were also really positive things that came out of COVID. And was the recognition of, there was a big gap with recognition around care partners and caregivers, but there were also a shift for a lot of people who recognize the value. And the relationship I have now with my dad's healthcare providers, all of them, whether they're specialists or family docs or whoever it is, has really shifted, and I really feel a positive involvement and very recognized. And I think that makes my job easier. And I also have a very supportive employer who knows that if I need an hour here to meet with home and community care or go to the family doctors, that I'll make that up somewhere. And I think that really helps that because my siblings, I have 6 other brothers and sisters, and some of them are in positions that they cannot leave their job. The job would shut down. And so I think that's kind of why it did default to me. But So I think the supportive piece is employers, your support network. I have a very supportive husband and children as well.
So one more quick question on this. You said, next time I won't be so fast to put up my hand. So is this a conscious decision that families should start to talk about before they actually need it? Because you can't actually predict when you're going to have a hip fracture. You can't predict when you're going to have a stroke, or you might need more care than you do today. So should families actually be talking about this?
In my opinion, absolutely. And I think because I have been through it so much, and with so many of with my parents and my grandmother, that I think that has made us talk about it early on. So, when my mom's health was failing, she was very adamant that my dad put in place something. And so what was that team going to look like? And that really helped when that transition happened. And it took about 5 years before, he kept saying, come now. And I said, you don't need us now. You need to be on your own and function independently for a while. And then we'll come in. And so it was a much more planned effort with my dad versus the other two. And that was because of a quick health issue that put us into sort of that urgent mode, or that mode to function. But I think everyone, all of us, even, my daughter's here tonight, and she would say that I'm also a planner, and I would be saying, this is what I need you to do, and this is what things will look like in the future. So I think planning is really important. Yeah.
So I've left you in a very awkward position here. You are the final speaker. You've got a ton of information on osteoporosis, and I'm going to ask you in the next 20 minutes, can you lead through the important things? One thing we can't see here as an audience is on everybody on TV, there's a key or a card in front of the speakers here. And Monica's got a card with her phone number, 1-800, I don't have it, 463-6842, sitting in front of her. So that is her number to call. She's more than helpful if people have questions that they could contact her. So again, 1-800-463-6842. Okay?
Great. Well, Keith, I think when Kathy had asked me to come and speak, and the three speakers were, as much as we sort of think sort of different topics, but very similar. And so what I was saying to Annie earlier on was how we look at bone health and osteoporosis is quite different in these recent years. And so as she talks about, heart health and heart attack, I'm really here to talk about the hip attack. And it's as bad and as serious as a heart attack. And thinking about Sandra's topic around caregiving, and really we don't need to kick in the care partner, caregiver part as quickly as if we can stay independent. And how do we stay independent? We have to stay well, and we have to prevent illness. And in my role, it's really around preventative medicine, and how do we prevent people from having broken bones caused by osteoporosis. And so the topics, although different, are very interconnected. And so really for my piece, it's really to talk about that shift in what bone health and osteoporosis is all about. It's really shifted. I've been with Osteoporosis Canada now for almost 17 years, or over 17 years now, I guess. And I've seen evidence change, I've seen research change, I've seen a real shift in how we look at bone health. And as you know, Keith, I told you a funny story about how I came to be here, which was I had been approached to come and work for Osteoporosis Canada, and I'd been in the healthcare, charity healthcare, national charity business for a long, my career. And when I was approached, the person said, I need somebody to work for us for Osteoporosis Canada and the Ontario Osteoporosis Strategy. And she said, I'm just wondering if you'd be interested. And I said, you know what, I don't think so. Because isn't osteoporosis like a disease that affects people's bones, but mostly older women? And she said, well, then she didn't really say a whole lot. And I knew I was scared because she's, like me, a real talker. So she gave me a minute or two, and then she went at me and said, okay, so if you, and you've been in different roles in healthcare and involved with, the senior population for a long time, and you're thinking it's a disease that impacts older women, then you need to come and work for me. You need to get out there, because if you think that, a lot of people think that. And so here I am, 17 years later, and still trying to spread the message about the importance of bone health and osteoporosis and how to prevent fractures, because there's a myth, or there's a bias out there anyway. Without looking at men versus women, there's almost an ageism piece around bone health, that people think, as you age, if you fall, you're going to break a bone. And so, of course my mom would break a hip at 92. That's what happens when you're 92. Well, that's not the case. And we know that not everybody that falls breaks a bone. And so once, you sort of say that out loud and go, that's true, because what Sandra and I do all week long is talk about fall prevention and staying independent, and knowing that 1 in 3 people over the age of 65 fall. So when we look at the number of fractures or broken bones, it doesn't equal that. We have about 60,000 osteoporotic fractures in Ontario every year. So it would be a lot more than that. That's still a lot of fractures, and that still really impacts the healthcare system. So we really have to get people to start thinking about, if I fall from standing height and I have a broken bone, why did that bone break? So it's not about age. Young people can have osteoporosis, and both men and women can have osteoporosis and can have an osteoporotic fracture. And that's the message tonight, is first of all that it's not about older adults getting osteoporosis or having bad bone health. It's really about how do we all look at our bone health and talk to our family doctors about, what is my chance? What are my bones like? And what is my chance to have a fracture? And in particular, what is my chance of having a hip fracture? Because that's going to change my life, or a spine fracture. So I think that's been the biggest piece, is getting people to understand that if you fall at 60 years of age or 55 years of age and you break your wrist, and people say to you, oh, and you're embarrassed, and you're like, oh, I feel so clumsy, I broke my wrist, I just want this over with, 5 weeks in the cast and be done, and hope that it just goes away. And that's actually what's created a really large care gap, and that what we know is that almost 50% of people who have a hip fracture actually had a broken bone, like a wrist fracture, in their 40s, 50s, 60s, and onward. So, again, bone health is something that we need to really pay attention to. So osteoporosis, so the actual disease, it's really, sometimes people get osteoarthritis and osteoporosis mixed up. So they are quite different, because osteoporosis means porous bone, and it puts you at risk of having a broken bone or a fracture. And it's interesting, in my years of doing this, people will say, well, I just had a fracture. That's not as bad as a broken bone. Or I just had a broken bone. That's not as bad as a fracture. Or my neighbor had to have their wrist fracture fixed by the surgeon, so her fracture was worse than my fracture. So they're all broken bones. And they're that warning sign that we need to pay attention to. And, it may not be osteoporosis. Your family doctor will investigate it to see what was that underlying cause of that broken bone. And so when people, we need to talk to the family doctor, find out what can we do to make my bones stronger. And also, the other big shift that we've seen, and I think it's important, is that we used to always say, I need a bone density test to find out about my bone health. And so bone density tests or bone mineral density tests are very important. They're an important test to have, but they're not everything that we look at now in regards to bone health. It's one part of the picture. So the very first conversation that I encourage people to go back to their family doctors or their nurse practitioners and ask, and that's for everybody over the age of 50, for all of us over the age of 50. What is my chance? What is my fracture? What's my risk of having a fracture? And there's a little tool that the family doctor or the nurse practitioner uses to look at your risk of having a fracture. And it's kind of like Annie was talking about, what's your risk of having a heart disease, or we really need to be looking at our health in what's a risk, what's my risk to have, this or that, and then how do I minimize the chance of that getting worse?
You told me about a tool called FRAX, F-R-A-X. And I actually did what you said. I went home and Googled FRAX, and I found the quiz, and I took it myself. Now, the only time that I didn't have my bone mineral density, so I couldn't finish it all, but I found it very helpful, and it's simple to do. But it highlights the risk factors that you've been talking about. So.
Absolutely. So there's the tool, the FRAX tool, that, and again, you would look when you are on a website, the FRAX website, you would look for the Canadian data to make sure that you're using Canadian data. There's another tool that your family doctor and the radiologist uses to also look at fracture risk, which is called the CAROC tool. And that also helps identify your risk of having a fracture. And once you know that your risk of having a fracture, then, if you're at low risk, moderate risk, or at high risk, and that means all of us in the room, there are certain things that we need to do to have good, strong bones, which is calcium, vitamin D, exercise, and, fall prevention, because we know that falls puts us at risk of a fracture as well. But we also, if you're at high risk, need to look at a drug treatment for osteoporosis. And so there's been a real shift in how we deal with osteoporosis and we deal with fracture risk in this last few years. And so when people call and they'll say, Monica, my family doctor would like to put me on medication, they think there's something wrong with my bone health. We always have that conversation about, what did your family doctor say your fracture risk level was? And so if they said it was high, then absolutely the drug treatment is that sort of icing on the cake when you're at that high risk level. But it's interesting because a lot of people still are really kind of honed in on the bone mineral density score, and density only tells us how dense your bones are, and so it allows us to have a T-score and identify whether you're diagnosed with osteoporosis. But lots of people live well with osteoporosis. The real, the sneaky part of osteoporosis, because it's silent, is that you could break. And so we actually have seen people with kind of half-decent bone density that will actually break a bone, and yet other people that may have poorer bones that don't. And that's where about 10 years ago, that shift around, it's not just about density now. We need to look at quality and quantity of bone to identify and actually talk to people about their risk level rather than really focus on bone density. And that's what I like about the FRAX tool, Keith, that you went on and looked at. You don't have to have the bone density score to actually get a number, to actually find out what that score is.
You can keep on filling it out even though you don't complete that section.
Absolutely.
It's not like a lot of tests. The thing that I read about osteoporosis, and I just want to talk a little bit a minute, is that if you don't, when you initiate treatment, you have the diagnosis, you initiate treatment, you can only prevent it, and you correct me if I'm wrong here, you can only prevent it from getting worse. You can't go back and make it better. Is that right?
So there's different drugs. So again, we look at, first of all, before you would be put on a treatment, the new guidelines or the current guidelines state that again, it's recommended if you're at high risk of having a fracture that the drug treatment would be, would be recommended. And the drug treatments are actually set up to stop the bone loss from getting your bone density decreasing. And in some cases, there are some drug treatments that actually improve the bone density. So we do see some improvement.
So I'm going to have to go back and read the reference that we put in the outline, because there was about 15 pages of drugs in there, and I must admit I didn't know them very well, so I skimmed it, but I'm assuming there's some details in there. The good news on that, though, is they're for people who really do have osteoporosis and fractures. There are some good drugs out there today.
Well, and I think the good news is that, again, if we put the interventions in place like calcium, vitamin D, and exercise, and there's different types of exercise, and again, it's important to know that, that you need weight bearing and you need strength training and all of those different components with exercise, and preventing falls is important. But by putting all of that in place, the main thing that we want to do is not have your bone density or your bone mass decrease. So if we can maintain that, that's our goal. And if we get some improvement, then that's kind of, I always say to people, that's the happy dance. So we want to stop it from getting worse. And again, people live well with osteoporosis. We have a great support group. We have the Canadian Osteoporosis Patient Network, and they will everybody involved with that organization will tell you that you can live well with osteoporosis. What they want to really focus on is preventing the broken bones. And so again, stopping your bones from getting worse. If you get that improvement, great. But it does take effort. There's things to minimize that risk. And again, some of those things we talk about in classes. We're really fortunate in this region. We have programs at Chickamick CHC, the Community Health Center. We have all kinds of programs through family health teams, through the family doctor's offices in this area. And so this topic, like we can spend hours just talking on a drug treatment or hours on exercise or different activities to keep our bone health good and strong. So if people are living with osteoporosis, have been diagnosed, or if they've had fractures, at risk of having a fracture, please reach out to, as Keith mentioned, to the phone number and just say, I'm from the Midland area, I'm from the Barrie area. Can I connect with the person in that area so that I can actually attend some of the programs? And what's really great is the Chickamick program that we run here in Midland. It's a 4-part series, and we also do it online. So we've had people, it's really been kind of fun. We had some people from South River join. I don't know how they found out about us, but so you don't have to be just right from the area because of the online presence. But yeah, so again, it's really stopping bone loss, and so the drug treatments will do that, and some will actually improve them. And if there is material for anyone in the crowd tonight, but also if you're online watching, please reach out to Osteoporosis Canada or go on to osteoporosis.ca. The website has fantastic information and resources to access.
Monica, thanks very much for taking a very important subject and squeezing it down to the really important things. And thanks for being here to do that tonight, Monica. I want to take a break for about a couple of minutes and just talk to you about our sponsors, and then to talk to you about our next event, which is exactly 4 weeks tonight. So, Glenn, Josh, you got the slides up? Our 7 sponsors who give us money so you people can come to the events free, but they also are so supportive to our committee. They give us ideas. They have lots of good suggestions. Many of them have been speakers here at one point or another. But those 7 sponsors are the Waypoint Center for Mental Health Care, Audio Hearing Aid Center with offices throughout Simcoe County, Mink Insurance, led by David Mink, but it's now known as McDougall Insurance, Georgian Bay General Hospital, who's been a longtime supporter of our program, the Center for Psychology and Emotional Regulation, headed by Anita Federici, Hillcrest Village Care Center, a long-term home managed by the Enns family, and Lois Lipton from Georgian North Real Estate, who provides commercial real estate and developmental services in Simcoe County. So let's have a great big hand for those 7 sponsors. And our next slide. How many of you have been in a hospital operating room? Was it good? Was it fun? Well, we're going to have fun at the next event because you're going to be sitting back in your comfortable chair. You're not going to be on a hospital gurney, and due respect to surgeons. You're not going to be wondering, when are they going to touch me? Anyway, so this is a more relaxed and hopefully be very informative to you. We have 4 speakers. As you would expect, we have a patient, we have a nurse, we have an anesthesiologist, and we have a surgeon, and they'll be with us 4 weeks tonight. The information will be out on early, probably Thursday, tomorrow. So if you get a chance, and there's a video with that gives you just a brief tour of an operating room, so as a little primer, so you can take a look at that. So see you all 4 weeks tonight for that event. The one plug I want to give is for the Blood Donor Clinic, again, Saturday, June the 3rd, 23, here at the Midland Cultural Center. So if you feel inclined, it's badly needed, always need blood, so most appreciative if you would show up. Okay, so let's go back a little bit. I have one quick question. Can I do a quick question and then ask us to summarize? Are we good at that? Okay, so heredity. Nobody's talked about heredity. So can I expect if my father had osteoporosis or my mother had very significant heart disease, are my risks going to be that much higher? But nobody's actually talked about how much risk there is to family history.
So,
who wants to take that first?
Well, Keith, I'll jump in. So the fracture risk assessment that your family doctor will do, one of the questions is, did your mother or father have a hip fracture? And genetics plays a strong piece in osteoporosis and osteoporotic fractures. And so that's why we ask that question. So also, on the other side, is if you're living with osteoporosis and you've had osteoporotic fractures, it's important to talk to both all of your children, both sons and daughters, about their bone health, because often, again, it's that bias about men not getting it is really strong. And so I've been at functions and support groups where, somebody will say, oh, I did mention to my daughter now about getting her bone, to talking to her, her doctor about her bone health. And I'll say, but don't forget to talk to your son as well and have him talk to the family doctor about their bone health. So very strong genetic piece, Keith. Okay. And that is one of the questions that your family doctor does need to know so they can assess your fracture risk level.
And Annie, for vessel disease?
Yes, so especially if you have family members, moms or dads or brothers or sisters who've developed heart disease or arterial disease when they're younger, so in their 40s and 50s, that's a big deal. But one unique thing, I thought, I didn't mention it, but if you're a man and your mother had aneurysmal disease, you're actually more likely to get it than if your father had it. So, and that's the same thing with daughters as well. So if your mom had aneurysmal disease, which is aortic aneurysms, then you're more likely to get it if you're a man. So it is related. Heart disease develops in everybody. If we live forever, we would all get it. Okay. So, yeah.
Okay,
yeah.
Thank you. So we're coming to the end, and I warned you that I would be asking each of you for a key message, either one that relates to your health or one that you think is important for the audience. And if you could just do that succinctly, each one of you, that key message, so that we can indel that right in our brain, and so we'll remember it, that we heard it here first. Yeah. Go ahead, Annie.
All right. Well, first I want to say thank you for being here. It's been very interesting. But the key message, I think I've said it multiple times, is that heart disease is really important in men and in women. and that the number one way that we should treat it is prevention, so lifestyle changes or treating people who are at higher risk. And I think that leads into my last point, is that women have different disease than men, but having a trusting relationship with your doctor or healthcare provider is very important in being able to have that open communication to find those risks.
Okay, thank you. Sandra.
So I think, like Annie, thanks for the privilege. It's been lovely to be here. You know, the literature or the data says that 1 out of every 2 individuals will be a caregiver at some point in time. So as you look around, half of you will be. So it's important to know, it's important to ask questions, it's important to have the conversations that Monica talked about with your families to make sure that you're clear. It's important to know the questions, it's important to take the time with your healthcare teams to really explain what you need. And most important, it's important to take care of yourself. And I think that's the one cross-cutting theme I've certainly heard. Self-care, 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 because if the caregivers go down, there's nobody to take care of their loved ones. So it's important to take care of yourself.
Okay, thank you. Monica.
And my message would be that knowing that 50% of hip fracture patients told us they were coming, they'd already had a broken bone, that it's important to talk to your family doctor about what is my risk of having a fracture so that I can do everything I can to minimize that fracture and be able to stay independent and live well. And I think that's the number one piece, is go back and have that conversation, and especially for the men in the room, because often they don't think it's a disease that impacts them. So thank you for having me.
So at this point, it is my pleasure to say thank you to all of you. And special thanks to our audience for coming tonight, those of us who are watching us on TV or online, or will be watching us online in the future. But I can't say enough about our speakers. They have just been wonderful. Whenever I meet 3 individuals, and I don't think you knew each other very well beforehand, you always wonder, how's it going to fit? Are they going to talk to me? Are they going to talk to each other? You were amazing, the way you interacted and the way we came up with some common themes. And all of these are game changer issues. Heart attacks, fractured hips, and needing a caregiver or being a caregiver. They change your life. And so important to bring that information to us all in the really succinct and clear way that you've done. So thank you. Thank you again for doing that.
Thank you.
Again, thanks to our 7 sponsors and to our audience and anybody else that wants to join us. We'll see you in 4 weeks for a night at the theater, otherwise known as the operating room. Relax and enjoy with us. If you'd like to watch this program again, you can Google YouTube Our Health, and it'll be available later tonight. You can tell your friends, or you can take a look at it again. I always watch it again because I know I've missed something, so maybe you're better than I am. But take a look at the YouTube video and tell your friends about it. So again, we will see you in 4 weeks tonight. Have a good night, everyone.